Zoll has pushed the boundaries of what is possible for 35 years, in the tradition of company co-founder Paul Zoll, a Lasker award-winning physician and a pioneer in pacing and defibrillation. In addition to his seminal research, Dr. Zoll had a reputation for dedication and careful attention to his patients. His legacy lives on at Zoll.
So what I'd like to do, looking at what non-neonatologists need to know about babies. And over the next 20 minutes, I'd like to just take you through a case history, which is going to take us from home through parents' actions, paramedics, emergency department, and actually very little about the NICU. We're going to talk about newborn resuscitation in those terms and perhaps highlight some of the similarities and also the differences as we go through and pick out some of the changes that have come through the ILCOR process. And I hope reassure all of you who are not the neonatologists here that actually everyone can do this. So the first case is Jessie, someone that I was involved with, although only later in the process. Mum delivered at 27 weeks at home, and she delivered in membranes onto the duvet on the floor early in the morning. The parents called the emergency services, so a dispatcher first of all, and were advised to break the membranes and assess the baby. Not breathing, no signs of life. So they were advised, and Mum actually gave mouth-to-mouth ventilations to her own baby, advised to move the chest. They fortunately got attended by both a single paramedic rapid response team and a paramedic team then arrived. And the paramedic, we'll come back to the importance of debrief perhaps, but said when I spoke, I saw a young girl with this tiny baby in her hands. She handed me the baby and said, "Please save her." And my heart sank. So they had a maternity kit and they cut the cord and assessed, and the baby was floppy, a few small gasps, blue, and the heart rate at that time they felt was less than 30. Mum was fine. So their priorities, they felt, were to keep the baby warm, to offer ventilation, and once they'd established ventilation, the heart rate was still less than 60 beats per minute, and so they started compressions. They actually placed baby on Mum's chest to come in, mask ventilated and gave compressions, used a bag valve mask, and they used 3 compressions to 1 ventilation. And they found that on the way in, of course there were 3 of them, which was fortunate, the heart rate improved slowly, and they transported Mum and baby to the hospital, arriving at 40 minutes of age, 27 weeks, remember. And of course, we were waiting in the emergency department. So that was important. The heart rate was around 60, just above 60 when the baby arrived, and the paramedics actually thought that it had dropped just as they'd come in. Placed on a heated mattress in a warm room, intubated, because we're neonatologists and we have to do that stuff, and ventilated. And the heart rate quickly came over 100, and we gave surfactant at that time. Pulse oximetry readings increased, and we changed to air to ventilate rather than the oxygen, and transferred to the NICU, and it was admitted with a temperature of 36.5. Birth weight was 840 grams. Actually ventilated for 4 days, then went on to CPAP, and eventually went home in oxygen and is now doing well. A couple of key things that you'll see we'll come back to. One is that the paramedics really thought about temperature right at the beginning and on transfer in, and the ambulance, in fact, was steamy in there, and came in to be placed on a heated mattress in a room that was uncomfortable for everybody. And that is, I think, why the admission temperature in an 840-gram baby was 36.5. This is Jessie, not Jessie now, it's Jessie now 6 months ago. She's not in oxygen now, but went home in oxygen. The bow around the head isn't compulsory. That's not a part of resuscitation. But this is Mum with the paramedics, who are now slightly less traumatized than they were at the time. And in fact, both these paramedics have now attended, at our expense, a newborn resuscitation course, although I think they did pretty well. So birth outside the hospital. In the UK, if it's a planned birth, then the chances of needing intervention are less than if you're in hospital. Certainly the chances of getting it are less, because it's a pre-selected group and they have interventions planned. But if it's unplanned, then you're more likely to be preterm, a multiple birth, previous history of precipitate delivery, concealed pregnancies, and it's much more likely to be complicated. And if we look at the data for around the world, although not in Asia, then UK, US, Italy, Norway, the incidence of born before arrival in an unplanned way varies between 0.44 and 1.8%. You'll see that mortality, in comparison to other settings, increases quite dramatically, 5.8 to an 11-fold increase. And they tend to be lower birth weight and a lower temperature, clearly increased morbidity as well. The Norwegian data, which is included there, shows that in 2008, of 430 unplanned deliveries, 194 were at home, 189 were on the way in, and 47 were other locations like train stations, airports, and shops. So what should we do if it's going to be a baby coming in or a baby delivering in either pre-hospital or emergency? We need to prepare the equipment environment. You only need a flat area, but you need to think about temperature, and that ambient temperature needs to be high. Gloves, suitable equipment sizes, we'll come back to that. A maternity kit, you're going to need cord clamps at some stage. And we need the timings, and you need to think about who's doing what. Importantly, and this isn't me. You can see there's far too much hair. I mean, importantly, if most of you working in the emergency department, you're used to thinking in trauma terms, cervical spine, airway. When with babies, maintaining a normal temperature, that's the cervical spine of newborn resuscitation. A wet baby at 21 degrees gets cold as fast as this guy standing out in the nude in 0. And none of us want to do that. And please, it's hot out here, but beware air conditioning. It potentially may be death to babies. Use a hat, dry warm towels, thermal mattresses, and 26 to 36 weeks, then think about plastic bags, even if you haven't got a radiant heater. And skin to skin for well babies if they're covered. You may think, yeah, we know all this, but in fact, papers show that hypothermia less than 36.5 degrees occurs in all settings, everywhere in the world, and it's associated with increased mortality and morbidity. When we did the ILCOR review, we looked at 35 references, and none of those were randomized controlled trials, of course. Only 3 of them were randomized controlled trials. But they all had a single direction of effect and a dose effect. And as you've heard, those are things that up the ante when it comes to looking at a grade recommendation. They're associated with increased IVH, intraventricular hemorrhage, increased late sepsis, respiratory support, and hypoglycemia. And for every degree below 36.5, the risk of mortality increases by at least 28%. There are not many things that you can say that about. Keeping babies warm also decreases morbidity. The 2 of those studies are quality improvement studies, which have shown improvements on a number of different modalities. But the Wyllie study is a randomized controlled trial which showed an absolutely definite improvement in pulmonary hemorrhage in preterm babies. So one of the things that came out of ILCOR was that we felt that it should be an international standard of care. Wherever you are, babies should be kept in that range, although the methods of achieving that are multiple. So just in case you think, it's hot here, I've come from the UK to here, and by shots, it's warm outside. But this is data from Malaysia from 2013, just over 3,500 very low birth weight infants admitted for intensive care. And you'll notice that the red line is 36.5. There's a lot of babies that are cool. So we need to use all of these things, radiant warmer and hats, possibly warm humidified gases. For preterm babies, polyethylene occlusive wrapping. And the delivery room temperature needs to be right for our babies, not for the professionals, and actually not necessarily for mum. You ask any mum if it's important, she'll have the temperature up. And possibly heated mattresses, not for everybody, but think about what's going on. It was important to our baby. The good news is, for all of you not used to babies, that most mature babies breathe by themselves within 90 seconds. They sometimes take a bit of time to get going, and very few need resuscitation, but all need assessment, and that can occur as you're drying and wrapping a baby. That's a potent stimulus to breathe. I don't know what your towels are like, but in the NHS, being tried by an NHS towel is a really potent stimulus. And we assess the babies. And colour and tone, you can see a baby, you get the feel for it if you're handling it, but the things that are going to be really important are the breathing and heart rate, because that's going to direct any future resuscitation. Of course, if you're not used to babies, the thing that they have that nobody else tends to have is an umbilical cord. And if the baby is well, then you can wait at least a minute or longer before you clamp that, so long as you're looking after the temperature. But usually it's clamped at about a minute after birth. And if you need to institute resuscitation, get the baby to where you can resuscitate them. So there are lots of algorithms, and they can be quite complicated with arms, but I would suggest this is the algorithm you need. Dry and cover the baby, maintain the temperature forever. Assess the situation, and then it's an airway, breathing, ventilations if needed, and usually start with air. Chest compressions only after effective ventilation if the heart rate is less than 60. And then drugs are in brackets because it's likely to be less than 1 in 2 to 3,000 that might warrant drugs for resuscitation. The assessment is easy. Colour, babies on the whole will be very rarely white shocked. They tend to come out a bit cyanosed and eventually go pink. Tone, normal, low, or if there's no tone, they're usually unconscious or very premature. Breathing, normal, gasping or not breathing, it's easy. And heart rates, I think, unlike you guys, there are only 4 heart rates when we look at babies at birth. Absent, which is a bit worrying, very slow, less than 60, slow, and fast, which is more than 100. And how do we assess? Well, standard is, on the whole, it's with a stethoscope. Pulse oximetry will give you an accurate heart rate if you put it on within about 90 seconds of placing it on a baby's wrist, preductal. And an ECG, increasingly, and from ILCOR, actually that gave a rapid and, if anything, more accurate assessment of heart rate if you could get it to stick. People have used the cord in the past, but if you feel a cord pulsation that's more than 100 beats per minute, yes, you can be reassured. If it's less than 100 beats per minute, you have no idea what's going on. So it's not accurate. The airway, so in an unconscious newborn, airway obstruction is usually due to loss of pharyngeal tone, and it's not usually foreign material in the airway, although that's what we all worry about, and we'll come back to that in a second. So it's position, not suction, which is important. Meconium, of course, we get worried about this, but in the last iteration of ILCOR, we found there was insufficient published human evidence to suggest routine tracheal intubation. So don't get too worried about it. Routine intrapartum oropharyngeal and nasopharyngeal suction is not recommended. Tracheal intubation is not routine and should only be performed for suspected tracheal obstruction, and that's a change, because we looked at the evidence and we graded it, and it was rubbish. So initiate ventilation within the first minute of life in non-breathing or ineffectively breathing infants, and don't delay it. So we've talked about airway. Hold the head in a neutral position. That's what we would say in the UK, although the Americans would tend to say sniffing the morning air. Whatever, you have to remember they come out with a big occiput. And so you don't want them in this position. You want the face parallel, because that's going to open the airway. If you overextend or underextend, it will tend to block the airway in an unconscious baby. You need a well-fitting face mask, and our babies come out in different sizes. You can deal with a baby that has a 10-fold difference in mass, 500 to 5 kilos. And the 5 kilos are getting more likely in the UK at the moment, I'm afraid. So it's got to be the right mask for the right job. And all masks are not equal. If you think they are, then look into the literature. Some of them are useless. Use jaw thrust. Bring the tongue forward. And here we see the mask is applied, it's got a good seal, and the fingers are supporting the jaw, drawing the jaw up into the mask without pulling the head back. Oops, I've gone the wrong way, sorry. Yeah. Also, if you have a problem, think about a 2-person technique. 2-handed mask and airway management is better than single-handed for all masks, in all babies, with all people. I don't care who you are. It's better for me too. And give ventilation breaths. And we can start with air, but use what you have. If you only have one gas to drive, use it. Obviously, don't use the Heliox because they'll give you funny cries. But for preterm babies, the recommendation was that you could start between air and 30%. That came out of the last recommendations. Ventilate, then reassess. If the heart rate responds, and it's the heart rate that we've assessed right at the beginning, you can assume the lungs have been inflated and you're ventilating. And on the whole, you will see the chest move. If the heart rate is not responding and the chest is not moving, then the lungs are not being inflated. And you've got to go back to A and B. I know that is obvious, but it's really important in babies. Nowhere else is it so important to get ventilation done before you go on to compressions. Compressions are easy to do. You can get a cleaner to do them as she's walking past, so long as you can teach her. But if you've not ventilated the baby, they are pointless. We can think if we've not got an airway that's working, oropharyngeal airways. Around the world, these are underused. And one of the reasons is that they don't come in enough sizes for all our sizes of babies, but they can be very useful. And of course, although I've kind of said don't go for immediate tracheal intubation in meconium, you have to think, is there something blocking the airway? And so you might have a look, and you need a laryngoscope, and you need, if you've find something there to suck out, it's got to be a large bore sucker, and suck under direct vision. Don't just prod in the back. Particulate airway obstruction is rare, but it can be due to thick mucus, it can be due to blood, vernix, and it can even be due to meconium sometimes. And people worry about airway obstruction, but if the airway is blocked, unblock it. If you want the grade level of evidence, come on. Compressions then, we would commence if the heart rate is less than 60 beats per minute or absent after effective ventilation is established. Make sure. Most babies will respond to 30 seconds of effective ventilation, and you need to think that compressions reduce effective ventilation. So we don't go for asynchronous, we go for synchronized compressions. And if you're delivering compressions, most people would increase the oxygen you're delivering. It's a 3-to-1 ratio that we use, and there are various reasons why we have stuck to that, although it's a grandfather clause that it's in the guidelines. You'll notice that these diagrams demonstrate thumbs overlapping. That is, certainly in mannequin studies, is a more effective way of delivering compressions. It's absolutely more effective than a two-finger approach, but even if you have a side-by-side approach, this is a better way of doing it, although it is more tiring. So what next? Well, of course, you'll have been successful in the vast majority of cases. So reassess, think about temperature all the time, wherever you are. Consider blood sugar, because especially in growth-restricted or premature babies, this process may well have used up the resources. What are you going to tell the parents? They need to know what's happening. And think about your records. And it's really useful to know time of birth, time of first assessment, time to first heart rate more than 100, and time to first gasp, and the time when regular breathing is established, and the actions taken. And think afterwards about a debrief. Certainly in emergency departments or for paramedics, and indeed in delivery suites, these are relatively rare events. And the common theme is that everybody just explodes back to their own areas and do not get a time for debrief. So even 5 minutes of a rapid debrief can be tremendously helpful. So in summary, this is, I think, the easy algorithm you need to think about. Dry and cover the baby, maintain the temperature, assess the situation. Airway, breathing, ventilation, chest compressions, drugs incredibly rarely needed. Even chest compressions will be less than 0.12% of babies. So after drying and assessment, you of course follow that ABC approach. The heart rate tells you how you are doing. Temperature control, airway and breathing and management will resuscitate most babies. And if ventilation is difficult, recheck the airway position and consider the two-person technique. And that's the final message.
Thank you very much.